Good morning, good afternoon, and good evening, everyone, and welcome to ICAP Grand Rounds. My name is Wafaa El-Sadr, and I'm the Global Director for ICAP at Columbia University. And I'm thrilled to welcome you today to our Grand Rounds that is entitled today. It's entitled COVID at 5, so what are the lessons learned and the way forward? We are thrilled today to have three individuals who were intimately involved and deeply involved in the COVID-19 response. For today's webinar, we're going to start by a presentation that's going to be given by Dr. Ashwin Vasan, and I'll introduce him very briefly, to be followed by a panel discussion that will include Dr. Vasan, as well as Dr. Fiona Braka, and also Mitch Stripling. So let me get started first and I need to also remind you to please, anytime during the webinar, you can place your questions to the panelists using the Q&A box. And of course, we will take those questions into account when we are in the discussion period of this webinar. And as always, with all of the ICAP webinars, the recording of this webinar and the slides will be posted on our website, and you can see the website address here on the screen. So let me get started first by introducing Dr. Ashwin Vasan. He is a physician, he's an epidemiologist and a professor at Columbia University Mailman School of Public Health, and he served as the 44th New York City Health Commissioner from January 2022 to 2025. Now, for those of you who are not aware or knowledgeable of the New York City Department of Health and Mental Hygiene, it is a very large entity, and it has more than $2 billion budget and more than 7,000 employees throughout the boroughs of New York City. And it is one of the largest and most historic of public health agencies in the world. Now, during Dr. Vasan's tenure, while leading the city out of the pandemic and confronting new challenges, including the 2022 Mpox outbreak, he helped reshape and reorient the city's public health systems to take into account other challenges, including falling life expectancy and establishing some very important programs in the city of New York, which aim to achieve healthier, longer lives for all New Yorkers, with a specific focus on closing inequities. Now, during the panel discussion, he'll be joined by Dr. Fiona Braka. Welcome, Dr. Braka. And she is the Emergency Response Manager of the World Health Organization Regional Office for Africa, that's based in Brazzaville, Congo. And she leads the regional response operations for acute and protracted health emergencies, including disease outbreaks and humanitarian crises. She has extensive experience, 2 decades of national, international experience with the World Health Organization, served in various positions in Nigeria, Ethiopia, and Uganda, where she led WHO efforts to eradicate the wild polio virus and to strengthen national vaccination programs. And then the third panelist will be Mitch Stripling, and Mitch is the director of the New York City Preparedness and Recovery Institute, PRI, and he's the author of a new book entitled The Epistemology of Disasters and Social Change. He also has a long history of leadership roles in emergency management, disaster response and planning, coordination, and response to public health crises. And before joining PRI, he served as a national director for emergency preparedness and response for Planned Parenthood. And prior to that, he also served in similar roles at the New York City Department of Health and Mental Hygiene, as well as also helping to implement responses in several other parts of the country beyond New York City. So without further ado, I'm going to ask Dr. Vasan to please share his screen and give him the floor for his presentation. Thank you.
Good morning, everybody. Great, the slides are up. It's good to be with you. I am a few hours ahead of Eastern time, which means it is very early where I am, and which means I'm a little subdued. So if that comes across I think it's a function of being so early, but also I think the topic and the time that we're in is one of great concern and makes me feel a little bit subdued, uh, for sure. And I want to thank Wafa and ICAP and everyone who's organized this Grand Rounds for a chance to do something that I feel we haven't done enough of, which is to really look back at this once in a century, perhaps once in a lifetime, public health challenge that we all went through together, and what must we learn? What must we unpack? And how can we avoid the challenges that we face from happening again? I realize it's um, a bit funny to say that, particularly for those of us here in the US. It's a bit funny to say that at a time when we feel like our public health apparatus is in some ways crumbling in front of our eyes. But make no mistake, we will be faced with these challenges again, and we must learn these lessons. And so these are 10 lessons that I took away from these last 5 years. And I was certainly not health commissioner throughout those last 5 years. I was health commissioner for about three. And so I share this with my colleagues, Dr. Auxiris Barbeau, who was the commissioner at the very outset of the pandemic, perhaps the most painful time of all, in at least here in New York City, and of course Dave Chakshi, who was came on board in advance of the vaccination campaign and led us through the initial phases of that. And so I want to recognize them because this is not work that we did alone. This is work that we did together. And of course, I want to also recognize my incredible former colleagues at the New York City Health Department and across the civil service in New York City at a time when civil servants are under attack. I think it's important to recognize how heroic their efforts were. And, for Fiona and those of you joining from outside of New York, the same can be said all over the world. And I hope we'll touch upon that a bit today. So thank you for having me. Next slide. I think it's important to start with the facts. We are in a time where um, even basic empiricism is under attack, basic science is under attack, but the facts remain. We had over 750,000 cases of COVID in this world, over 7 million deaths, 1.2 million deaths here in the United States, and over 45,000 in New York City. And as I described, half of those deaths in New York City happened in the first 3 months, approximately. And you can imagine the how painful that time was. I not only um, had the honor of serving as health commissioner, but I was a nonprofit leader at the time, and I was also a practicing physician. So I remember those times quite vividly, going to, cough clinic, um, being very afraid, confronting my own fears for my family. I have three small children, and fear of what would I bring home to them. And I just remember so vividly that time of fear and that we all went through, particularly here in New York City. And I think it's important that we don't forget that. Some of the modeling that has been done since um, the onset of the pandemic suggests that up to 36 million excess deaths that wouldn't have otherwise occurred, that are either directly or indirectly linked to SARS-CoV-2 infection, may have occurred over the last 5 years. Nearly 2 years of total life expectancy lost globally, and nearly three in the US and two in New York over the last 5 years. And while there are encouraging signs that is improving, we can see that countries with stronger health systems, stronger social safety nets, more equity, have recovered faster. Long COVID, um, the complications and disability created by long COVID affecting hundreds of millions of people worldwide. And we're still yet to really truly unpack the ramifications of that. And, it makes it very disturbing that the new government doesn't wish to follow that up and is attempting to close those research projects. And of course, those early days for any of us who touched the front lines of the response, how overwhelmed we were, how overwhelmed people were, whether you were working in communities, whether you're working in hospitals, particularly hospitals and health workers. And I say that in part because um, one of the things that made this pandemic so real for New Yorkers, but maybe hard for other people to understand, was that it was somewhat invisible to people. It was happening inside these big healthcare systems that were closed off, and yet for those of us who touched those systems, who did walk through those hospitals and healthcare facilities, we could see it very vividly. Now, many of us were affected in our homes and communities and could see that, but this wasn't the plague. This wasn't pestilence. This wasn't rampant disease across our streets in the way that we have been documenting since Camus and before, right? This was something different in many ways. I think of it as a Goldilocks virus. Everything was just right, just bad enough, just severe enough, just transmissible enough to fundamentally disrupt our social ties, our economic ties, and of course, cause a lot of death and suffering. Next slide. And so I just want to take us through a few images to cause us to remind ourselves. I mean, this was a COVID memorial built in 2021 on the mall. One thing that makes me quite sad in the United States is that we haven't yet decided that we want a permanent COVID memorial. And I don't understand how you can move forward from a global challenge like this, from a challenge that took so many people away from us too soon, without remembering. And it does appear at times that we have a collective amnesia, that we just want to forget this ever happened. And I understand that instinct. It's a very human one. I don't think it's a pernicious one. But I also think that we must force ourselves to remember in order for us not to repeat um, these mistakes. Next slide. I'm glad other places like the UK have decided to make permanent memorials. This is the COVID memorial on the south bank of the Thames, and I've run by this and walked by this several times, and it's just extraordinarily moving. And I hope it will be a permanent feature. It seems to be a permanent feature that will, I hope, just remind us once again what we've all been through. Next slide. These are the refrigeration trucks that were carrying bodies um, out of our hospitals. This is actually the one that's around the corner from where I live. So I walked by, ran by, cycled by, drove by on my way to my own facilities where I was working each day, which had their own trucks. A very, a very painful time to see. Next slide. And something I never thought I would live through is mass burial. This is on Hart Island in New York City, um, for people who are unclaimed or we couldn't connect to any living relative. The fact that we had to place them here in this place was extremely cruel, a cruel reality. The number of Zoom funerals that happened with people in the ICU, or the distance that this virus created shattered our social ties in such ways, and caused so much pain. And it's still something that I think about daily, and really um, hope we never have to go through again, because it shatters our basic humanity in such important ways. Next slide. And of course, the response. Um, there was such a visible response here in New York City, which was so impressive. for all of us. And it really was everybody working together. The government stepped up in extraordinary ways. Um, but even the private sector and other groups and community organizations stepping up in just extraordinary ways to to show New Yorkers and to show people that we were here to help. I know that even though there were times where it was confusing to know who was doing what and which organization to go to and who had appointments and who had tests and there were lots of logistical challenges with that. It was reassuring to me on a human level to know that there was a visible response on on many street corners across our city. Um, and for most people within walking distance or a short trip, there was someone somewhere, someplace you could get help um, for COVID, and that was definitely a reassuring aspect of the response. Something that we should really remember that that visibility is important. Next slide. And then, of course, the vaccination campaign, which um, was a time of great hope. I remember when I got my vaccine and when my family got vaccinated, what a sense of palpable relief that was, and how um, important I felt that was, and protected I felt, how protected I felt, regardless of the relitigation of all of that. That first wave of the vaccine was so critical for our physical well-being, for saving lives, and also for our mental well-being and our reassurance. So um, I remember this, and this is obviously an image of the first vaccination given in the United States to a nurse at Northwell. Next slide. So let me take you through 10 lessons that I've learned, and some of this comes from my hat as commissioner, former commissioner, and some of this comes from also being an observer of what happened across this country and the globe. And some of this, of course, comes from my perspective as a nonprofit leader in the early days and as a clinician. Um, Number one, so many of the issues around the response came from communication. And I want to just preface this. These 10 lessons will sound somewhat critical, but I only say that not to critique the response, but rather to say these are the things we can fundamentally control. These are the things that we can fundamentally work on so that the next time um, we are better prepared. Communication is critical. Consistency of message is essential, but so is adaptation of that message. And I think that's where we could have all collectively done better. The we, when I say the we, it's everyone involved in the response, not New York City or any one particular place, but we, the collective we in public health, could have done better to adapt our messaging to current information. You know, by in the early days of the when we didn't know as much about transmission and the nature of SARS-CoV-2, social distancing, for instance, was a reasonable strategy. By May or June or July of 2020, it became clear that that wasn't going to be a as much of a helpful tool. So we could have, for instance, adapted that messaging. But I think it became hard. It became very challenging for us to do so in public. And I also want to just make sure we say very clearly, at least in the US context, um, the very first day when we saw the president, now the current president, the former president, um, step up to the lectern to talk about coronavirus when it was declared a pandemic and when the first cases were arriving here. We all watched with extraordinary attention because the president is standing up and making an address to the nation. And if he had said, we don't know much, but we're going to mount a vigorous response, trust your local public health officials, your local doctors, trust your officials, trust Tony Fauci. We will give you the information as it unfolds and we will mount a vigorous response. That's all he needed to say to reassure the public. Instead, he said a lot of other things and he sowed a lot of doubt and uncertainty. And that really was the original sin of the pandemic from pandemic communication from my perspective, because that put all of us in public health on the back foot and having to kind of scramble to sort of project certainty when the environment around us was, and the leadership from the top was projecting uncertainty. And so I have a lot of empathy for Tony Fauci and everyone involved at every level of government for having to kind of come out with certainty, given that the leader at the top was projecting so much misinformation and just sowing distrust. It's important that we show our work. It's important that we are transparent. It's also important that we communicate as humans and that we're authentic, and that we bring some of ourselves to this. As a, I talked often about being a dad, being a family member, and being a clinician. All of our different hats. We're not just officials. We have to communicate as officials, but we're also human beings. And I think that that is an essential essential tool to build trust. And of course, who's giving the messages? It's not just the grass tops officials, but it has to be grassroots. In New York, around the vaccination campaign, for instance, we organized about 2,000 community conversations in advance of the rollout just to start to build that kind of confidence and trust. So I give a lot of credit to my colleagues for that. Next slide. I'll move a little faster so I can get through the rest. Data systems are a moral tool. I think it's an abomination that public health, a field that is, you know, meant to save lives and prevent suffering, is working on such antiquated, retrograde data systems, whereas Amazon and Google and people stealing your data and taking your data for consumer purposes can work on 21st century systems. We have to get better. We cannot allow this to persist. We have to modernize our data, automate our data, standardize our data, integrate our data for better surveillance. And we have to work and partner with industry on this, as much as that might not be something we want to do. And particularly when we see the tech industry moving in ways that are politically controversial for us, we still have to learn from their skills, bring in those skills into government and who's working for the public good, and build the data systems that people deserve. This is a moral issue as much as a technical one. People deserve better data, and we have to invest in it. And we began that process certainly in New York, but there's so much more to do. Next slide. Public health is operational. I think one of the things that was revealed in our field is that we have a very strong analytical and scholastic bent, and that can sometimes make us slow to action or slower to action than we'd like because we want to get it right. And we should get it right as much as we can. But as I said in my opening remarks, being visible, being immediately out there, communicating what you know is essential. Bringing information and care to people, not just expecting them to come in for care, is essential. Moving with imperfect information is essential to build trust. In that regard, healthcare is a key tool and a key partner, but not the navigator of the response. And we had a lot of challenges with that in New York, but it's a partner to be organized and deployed for the population, in alignment, and because they have those operational capabilities that sometimes government can be a little slower to deploy, and government can deploy it in one way, and healthcare can sometimes deploy it in other ways, community groups in other ways. And of course, we remember all the challenges we face with commodities and stockpiles. So it's not just a question of stockpiling physical commodities, but I'm really impressed with the work that the team did during my tenure to create some, like virtual stockpiles, and the ability to move quickly and ramp up production quickly because of pre-positioned contracts and agreements. Next slide. This is a big message for public health. The trade-offs are real, and we ignore these at our broader peril. Of course, there are economic impacts and business closures and impacts and job losses and homelessness. The stimulus that we definitely needed certainly contributed to inflation and to our affordability crisis. And some projections coming out of World Economic Forum suggest that they're up to $16 trillion in economic losses globally, to say nothing of educational impacts. New York, thankfully, was one of the places that opened schools relatively early back in reopened schools relatively early to back in the fall of 2020, whereas other school districts in the US stayed closed throughout the year. And we're still facing the persistent learning losses and academic performance gaps for that generation, to say nothing of social and emotional declines, including rising um, anxiety and depression and teacher burnout and high rates of turnover. Um, I think this also gets to this issue of what is our role in public health decision making. At the end of the day, I or any of my predecessors, we are not a democratically elected official. And while I am responsible to the public didn't choose me. An elected official chose me. And so it is indeed our job to give the best public health advice to the democratically elected government official. At the end of the day, that official has to weigh some of these trade-offs, and we can and it was all solving for different things. The purest answer to save the most lives possible was certainly to do some of these really hard things like lockdown and closures. But when you're managing a city or managing a state or a country or beyond, you have to think about these trade-offs. And it is not the necessarily the role of public health to to be the communicator of those trade-offs because we are again we are here to save lives, prevent suffering, and advance an agenda that can improve health. But there are other leaders out there, democratically elected and accountable, that have to communicate those trade-offs. And I think it is important to remember that as we think about the externalities and impacts of some of the public health um, approaches we took. Next slide. Speed and equity is not a trade-off. The curve you see on the right is the hospitalization rate by race in New York City during the Omicron wave, and the red curve at the top is Black New Yorkers, and the purple one, second to the bottom, is white New Yorkers. It was a 2-to-1 ratio, and it reinforces once again how the impact of this virus was so disproportionate on low-income Black and brown communities, particularly the Black community in New York City and in urban environments all across this country. Um, and what we learned, both in this response and, of course, looking at MPOX and future responses, is that speed and equity are not things that you can trade off. And in fact, we have to figure out ways to do this simultaneously. That means when we launch a mass testing or vaccination site at a population-wide level, we also have to be going very specifically into communities that we know have a high risk of being left behind for a whole variety of reasons. And it may also be that it isn't government that should mount that localized response, that it should be deferred to a local trusted community partner. So we can do the big fast, and we must also simultaneously do the hyper local. And the challenge is that we haven't always balanced that, or we've done the equity work or the localized work later because we say we build the big testing site or the big vaccination site first to get as many people in as possible. But we know that that always and persistently leaves Black and brown and low-income New Yorkers behind, and people behind across the country at least. So that means also, really leaning into nonprofits that are local and trusted. We used emergency dollars to build something called Public Health Corps, and now we've tried to make that permanent, leveraging community health workers at local, hyper-local, sometimes very small community organizations to mobilize local people because they're trusted members of the community. Um, History is an important thing to both name and acknowledge, but not to stand in the way of an emergency response, right? It is really important that our history is acknowledged and talked about, and that mistrust and historical mistrust is named repeatedly, but not in the way that it gets in the way of our ability to save lives and emergency response. And so our act of doing that regularly is really important. And lastly, we need to show up. So we need to be in the communities during peacetime and during an emergency. This is why the Pandemic Response Institute was set up. This is why We have neighborhood health action centers from the city government here in New York. And there are lots of different models of this across the country and the world. Next slide. Don't forget mental health. I think this is a huge byproduct of the pandemic that we're still unpacking. I mentioned to you my own personal fear. We all face different fears. Many of us face direct trauma, indirect traumas, so much loss. And this started to bear out in our data. We saw increases in mental health crises, particularly amongst young people, particularly amongst teen girls, particularly amongst already marginalized and at-risk teens. We saw increases in substance use. A 2021 survey in our city showed that up to 40% of adults were drinking regularly, multiple drinks a day per week. We saw increases in anxiety and depression that haven't really ebbed. And of course, baseline social anxiety, social isolation, and loneliness. And so that triggered us in 2023 to do a first of its kind citywide survey of mental health post-pandemic to say, where are we and where have we come from and where are we left? Next slide. I think this is an important conversation around when we deploy mandates and how. The way that I think of it, especially now, in the unpacking of this pandemic, is a balance between the actual risk of the virus or the health challenge that you're facing. So can you articulate clearly the risk to human health for everyone you're asking to do this thing? What is the intervention itself and the imposition of that intervention? So is it something that I would regard as relatively simple, like masking? Or is it something more drastic, like lockdown? Is it something that is short-lived? Is it something that is long duration? And where I think we saw so many societal breaks here was that we all had very different definitions of imposition. That even simple things that I thought were very simple, that many of us thought would be so logical, like just wearing a mask indoors when you're around a lot of people, became highly politicized and with highly different definitions of imposition. And we have to take that into account. And then, of course, what's the evidence of the intervention, right? We know masks work, and the fact that that was getting relitigated was very hard for us. But getting that balance right means we should really deploy our mandates judiciously and carefully, even if they are well intended, that there is a fallout, and that the fallout is that it can impact trust over time. Next slide.
If you can please speed up.
Yep. I think there's only 2 or 3 more slides.
Thank you.
I can't, the macro environment of mistrust and misinformation is something that I don't think we've even really understood how to get our head and our hands around, because we're fighting this battle against weaponized forms of misinformation. As I mentioned, there was an infodemic coming from the very top of US government during the pandemic. And so that made things extraordinarily hard for lower level officials. This has contributed to a continued rise in vaccine resistance, not just hesitancy and skepticism, but now full out resistance. In Texas, nearly 100,000 people this year applied for an exemption. That's a record. An exemption to routine school vaccinations. That's a record. Obviously, there were attacks on public health workers across this country and world. I experienced some of that myself. But we cannot just let it happen. We have to fight back. Very proud of the team here in New York that established a misinformation unit. There's weaponized in language. And so the last piece is language access. There's in language misinformation, very hyper targeted. So we need to combat that with the right information in the right language. But I think where we have so much work to do is on the tools. We have to get better at using the modern tools of technology and communication. Next slide. We have to protect our public health workers. They are essential. We have to treat them as essential. That means investing in better workplace cultures, better mental health supports, better pay, better supports for the workers who are caregivers, who have children, who have elderly parents. We have to invest in our managers in large organizations like the one I led. It isn't me that is leading people day to day. It's their teams, it's their managers. And we have to invest in those managers so that they can create better cultures in their smaller teams. We have to create more flexibility and upskilling for people can do different jobs in emergencies. And we have to celebrate and recognize regularly. This builds morale. Small things make a difference. Last lesson. If you can look and find heroism everywhere. I think one of the things that makes me so sad about this pandemic is we seem to have forgotten how many people helped each other. Small things, food banks and checking in on your neighbors and just the kindness that so many people showed in this city and throughout this world. All we talk about is the failures. All we talk about is the challenges and the mistakes. But there was so much good, so much goodness in us that came out. So, in addition to that human story, there's also really good operational stories. I mean, Operation Warp Speed was an unmitigated success. There were challenges, of course, with global equity, and I raised my voice on that as soon as I became commissioner. I knew that we needed to get vaccine to the developing world quickly, but there was so much good in that campaign, and so much good with our public health workers and nonprofit groups. I think we just glossed over it and forgotten it, and that's very painful for someone who was a part of the response, and I'm sure it's painful for many of you too. Next slide. I think there's only two more. Look, I mean, I'm well aware I'm giving this talk in the midst of a global backsliding on public health and global health. Um, we've just lost hundreds of millions of dollars here in New York. Every state across this country is losing money for public health. We're losing money for basic health care for the poor, which is going to make us less healthy and at greater risk. And we've completely retreated, or we want to completely retreat from global cooperation. I didn't even write. I forgot to write WHO. We've just said we're not interested anymore, and that sets a tone for the whole world. And I am still unpacking what that means. I don't have the answers, but I have maybe a few ideas. Next slide.
I think we're going to get into that in the discussion maybe as well, Ashwin.
Great. Let me just say that in the absence of leadership from the United States, we have to think more locally. We have to think in our own local control, our own states, our own cities, our own communities, where we can build up more local public health action, more prevention, support each other. And we need other countries to show the way and to be the leaders that the United States has said we're not interested in being right now. So I'm looking forward to the discussion. If you could just go to the last slide, please. I just want to show the last image, please. This was a beautiful thing we did here in New York City to recognize the victims in 2021, where we memorialized them on the Brooklyn Bridge. And again, I really do hope that leaders here in New York and across the world will decide maybe we need some sort of permanent remembrance here so that we don't repeat these challenges going forward. So thank you for your time. Thanks, Wafaa.
Thank you very much, Ashwin. Thank you, very much appreciated. And I think your very thoughtful reflections are going to inform a lot of the conversation moving forward. I invite Fiona and Mitch to please, if you can turn on your videos, to join the discussion, and then we'll take some questions from all of you in the audience. I'll go to you first, Fiona, and if briefly you can, I'm sure some of your reflections on the pandemic in Africa in particular may intersect with what Ashwin just shared with us, but from your perspective, briefly, what are sort of other flavors to these thoughts and lessons learned from your end? Before I move on to you, Mitch. Okay, go ahead, Fiona.
Thank you, Wafaa. Thank you to ICAP for this opportunity to be part of another grand round. It's a pleasure to be here on an important reflection of a crisis that affected all of us, all corners of the world at unprecedented levels. So we felt that impact in Africa. We were hit as well. And this pandemic demonstrated the the importance of health, not just as a central part of development, but also fundamental to economies, to societies, to national security and political stability. And I recall back in 2020, I was in Nigeria at the time, working in Nigeria, and we were the first sub-Saharan Africa country to get COVID case. And we were gripped with fear because the world had been waiting for Africa to have a case and thought that maybe our systems were not picking it up, but it was picked up pretty quickly from a traveler that had come in from Europe. And just to say for Africa, the predictions early in the pandemic were really grim. We had predictions of a very somber picture of numerous number of cases and deaths, but the reality was different. When you look at the statistics, it was thought we would have over 200 million cases and over 150 million deaths in just the first year. But that wasn't what happened. We ended up by late last year, 5 years into the pandemic, with just close to 10 million cases and 170,000 deaths in the 5 years of the pandemic. And we contributed 1.2% of all the global cases and just 2.5% of the global deaths. So the Africa region remained one of those that was least affected by the pandemic. But I want to say that we were not prepared, just like most of the world wasn't. Our systems were not prepared well enough to be able to absorb this shock. And at the same time, many of our countries grapple with multiple other crises, infectious disease outbreaks, humanitarian crisis, conflict that leads to other public health situations. So at any one time in the region, we have over 100 public health emergencies that we are dealing with. So it was a stretch on the system, but we have learned many lessons from that. We learned that preparedness is key. It costs much less to be prepared than to respond to the devastation of pandemics. And yet many of our countries did not have not invested in preparedness, in developing all hazard plans, in investing in the resilience of health systems around the human resources, the supply chains, and the healthcare infrastructure. So preparedness was one key lesson for Africa. The second was about global solidarity and cooperation. And we were on a receiving end of the lack of that at the beginning because we struggled to get access to medical countermeasures, vaccines, therapeutics, and diagnostics. And we know that we needed to cooperate in terms of information sharing. It was a global crisis, but we struggled with that on the continent. Another key lesson for us was the importance of public health surveillance. I think it's already been mentioned by Ashwin. Surveillance systems to detect, to describe, to guide the response from an informed perspective, the need for standard tools and case definitions that were agile as the outbreak was evolving was a very important lesson. We learned the importance of misinformation during outbreaks. We felt that in the continent, and the fact that we need to galvanize communities around the interventions. Vaccine hesitancy played an important aspect of the response here, that once we now had the vaccine, there was hesitancy, and it resulted in low vaccination coverage. We achieved just 38% vaccination coverage compared to 67% globally. And this was because of aspects related to cultural beliefs, contextual factors, the things that needed to be contextualized, tailored messaging that needed to be adopted to the communities. I'll also just highlight quickly the importance of research. We recognize the value of investing more in local research. We are doing a lot on the continent, but not communicating that enough. And this is important to contribute to the global wealth of knowledge and the need to invest in local research capacities. And my final lesson I would share is that the pandemic exposed vast inequities within the region. So in terms of access to healthcare by vulnerable populations, socioeconomic disparities, we have a lot of displacements, internally displaced people, refugees, remote areas. That plays an impact on our interventions, and all these needed to be carefully tailored for us to address and contain the outbreak in Africa. So those are just some lessons. It's a big topic, but I hope that gives you a flavor of what our experience was in terms of lessons on the continent.
Thank you very much. That's very helpful. I hope that everyone can stay with us till 15 minutes after the hour, because this is an important topic. So let me move on to Mitch. And I know that New York City PRI did embark on a review of the COVID response in the city. So I'm wondering if you can share with us some of the early insights that are relevant to our conversation. Thank you.
Sure, and thanks, Wafaa. Thanks, everybody, for this conversation. You know, we tried to look at COVID-19, building on what Ashwin said, in terms of its societal impact, not just focused on public health, but how did we all do as a society to stand up to it? And, you know, what was surprising to me was that when we talked to people in the neighborhoods, how much they wanted to help, how much they wanted their heroism to be part of this response, and then how exhausted it made them, how much trauma it kind of put on them and their families. Around the world, we saw people step up and do mutual aid, just like we did in this country. The key fact, though, is that in other countries, that mutual aid, those networks of support we saw, many of them are still in place. They're still happening in countries like Italy and countries in Africa. In the United States, it mostly fizzled out because people didn't have the ongoing support to do it. So the number one lesson that we find from our insights is that we need in this country to do a better job of building a network of response that highlights neighborhoods, that highlights community-based organizations, that brings in the vast efforts and energy and heroism in those groups into creating a big response. So that it's not a governmental response and a societal response. We need to figure out how to bring everyone together. And I can hit two questions in the chat, I think, in answering this. One question was about Black New Yorkers in particular and looking at their mortality rates. The city did an amazing job of focusing some of its efforts on what they called TREE neighborhoods, Task Force for Racial Inclusion and Equity neighborhoods, 37 neighborhoods in New York City that saw the highest disparities. And to your question, what we can do is focus more of our resources on those places where we know those disparities are worst. That's what PRI is trying to do. It's what the city is trying to do. And we also have to acknowledge another question was about public-private partnerships. We are in a different place now than we were in COVID, as Ashwin was saying. We're in a different place in terms of governmental commitment. We're in a different place in terms of public support. Public-private partnerships are going to be essential in getting us through the next few years. In talking to corporate partners in New York City, there's a lot of willingness among the private sector leaders to step up and help, but they want to make sure that they're doing it as part of a coalition where they can lead along with government, along with community leaders. It's really incumbent on all of us, and I think this gets to Ashwin's point about values, to bring together societal leaders in the same room to wrestle with some of these questions now, not just about the moral questions, not just about the operational questions, but also about the funding and the financial questions. We are all in this together. We have to create a societal network that's ready to take care of each other, no matter where we are, across all walks of life. That's something that we can do now, even the way that things currently are from a governmental standpoint. And I think it's something that we're hoping to contribute to at PRI as our findings come out, as we build partners around solving some of these issues in New York City and across the country.
Thank you, Mitch. Maybe I'll go back to you, Ashwin, and ask you, when we think of innovations, we are often thinking of innovations like technological innovations, like a new vaccine, a new diagnostic, and so on. What are some potentially important policy innovations that you can think of that would be helpful as we tackle the next, as we prepare for and tackle the next health challenge, whether it be climate challenge or an outbreak, or I mean, what are things that kind of often we need to transform some of our policies and to tackle these kinds of urgencies?
Yeah, and I'm not sure I'd even call it policies. I think it is in some ways down to administration and implementation. Sometimes we get in our own way. And, sometimes each regulation or rule is well-meaning. And often that well-meaningness is intended to ensure that no one's left behind or that the public interest is protected. But when you layer all of those things on top of each other, that's often it makes it very hard for government to act, or at least to act quickly.
Yeah.
And so one, I think we need to create some standard practices to waive some of those rules in times of emergency. We did some of that with the pandemic emergency, but we could have done better. We could have moved faster. Number two is, I think I mentioned it with particularly like supply chains. And the other piece we didn't talk about was emergency staffing. Have those relationships in place well in advance. Create pipelines and virtual contracts or pre-position contracts or commitments, purchase commitments, so that you can move quickly. Number three, I think, technology is essential, but it's not just centralized technology, right? It's not just let's build a nerve center. We certainly need a nerve center for better surveillance, and I think government public health is the right place to house that. But we also need to decentralize that technology into the hands of local community organizations and community leaders and even consumers and patients and people, so that they can feel a part of and control of this. And we did this in some ways, like, type in whether you're feeling symptoms before you enter a space or something like that. But none of that data got really used or scaled in ways that could drive population insights. So I think those are just three examples. There's many more. I do want to just say also with Mitch, what Mitch's comment is totally right. Public-private partnerships will be key, but also resourcing the kind of mutual aid networks at a local level. Finding permanent resourcing for that is going to be essential for the next pandemic.
Yeah, thank you. That's very important, and it reminds. What you just said is also makes me think of another question for Mitch, which is I recall several months ago where PRI put together people from corporate sector, innovators, and communities and the focus was on diagnostics, for example. And maybe you can share a bit of the philosophy and how that was conceptualized and what the goal is of pulling together these different stakeholders.
One thing about pandemics and emergencies of all kinds is that they're actually high-level sites of innovation. You see a lot of energy in a short time, and we saw that during COVID. Unfortunately, often that energy goes in different directions, right? Your corporate researchers go in one direction, government goes in another. The trick is to align those incentives together so they're moving in the same direction. There's a question in the chat about ventilation systems, for example. I personally think that this was one of the things that New York City did so well with schools, but it's something that for whatever reason, society didn't jump on advancements in ventilation in the way that it could, I think, to see downstream impacts all over the place. So what we tried to do with diagnostics was bring together the leading researchers, the corporations who wanted to sort of sell and market these things, the governmental regulators, and crucially, people who were impacted by the ongoing COVID-19 pandemic, who had suffered loss, to be moral arbiters and to bring their very real expertise to that discussion. And it's important that we've got to treat that expertise as real. We've got to pay for it. We've got to compensate people for it, to create a vision that everybody can get behind. And that vision is possible. It is there for the taking if we can have the courage enough to bring the right people together to endure the arguments, to endure some of the strong feelings, to get to an aligned solution that's better for everybody. That way we can channel innovation to sort of lift all boats in these emergencies. That's possible, and I think it's something we've got to do in the next few years.
Thank you. Maybe going back to you, Fiona, you mentioned something in your previous response, which was this triad of challenges that the continent faces. Often it's not it's not only one infectious disease, it's multiple outbreaks of now, for example, Ebola in Uganda, and then Mpox continued outbreak, and at the same time also climate-related threats in the continent, and conflict-related humanitarian challenges in the context of limited resources. And I'm wondering how, how is the region and how are you trying to assist in terms of moving towards a resilient health system that can help tackle all of these and be ready to tackle these diverse challenges?
Thank you. It's an important question. We have such a range of emergencies going on, and we go through this process of after action reviews for these crises, even during the crisis. And I think it's pointing towards the need for more investments in the systems. Our Director General likes to talk about the two sides of the same coin: health security and universal health coverage or primary health care. You cannot achieve health security without investing in systems. So we've learned a lot. There's been a lot of reflections in the region and in the countries to identify key inputs that within our resource constraints that we must invest in to be better prepared to address these crises in a sustainable way. And a lot is being done to advocate with governments, with the member states, to invest more into building these capacities, the human resource capacities, the logistics, and all these other elements that make the system much better prepared. We have been working as WHO with Africa CDC and the partners to help countries to build those capacities. So just taking a few examples around preparedness, for instance, the workforce element, which we identified as one of the central factors that contributed to whether a country was able to respond better than another. We have been working with them to identify local capacities in a multi-dimensional or multidisciplinary approach. So recognizing the contribution of not just health, but the other dimensions, and coming up with a minimum skill, minimum pool of emergency responders, multidisciplinary responders, training them and having them ready to respond. So to date, we've worked with 30 out of the 47 countries in the WHO Africa region since 2022, and we have a pool of close to 2,500 local capacities in the countries that are already being utilized. Because remember, in the pandemic, borders were closed. We could not move people from one place to another to help countries in need. So our target is the local capacities. We are also working with them to strengthen coordination mechanisms at the national level and the subnational level. One key lesson was the need for decentralized response to be in place to effectively coordinate. So this concept of public health emergency operations centers being in place in the countries, not just counting them, but making sure they are functional with whatever it entails to be functional. So to date, we have 40 countries that have national public health emergency operations centers, and 38 of these we would say are fully functional, and they're already helping to coordinate response. We have also worked with them to stockpile. So we have, for instance, in WHO set up a sub-regional hubs where we are stockpiling critical supplies such that when an emergency occurs, we can quickly deploy. With these investments, we've been able to reduce the average time of deploying critical supplies from 3 weeks that it would take us to bring supplies from Dubai and other parts of the world to just down to 3 days in the continent for countries that are in need. We have also been able, with these investments in workforce and supplies, been able to reduce the time for containment of outbreaks by 60%. We used to take us an average of 156 days to close say an Ebola outbreak, Marburg outbreak, we are down to an average of 63 days as of last year for us to contain these outbreaks because of these investments locally. You saw the case of Rwanda with Marburg, Tanzania, and now Uganda. Hopefully we will also we're working towards closure. But we are also working towards better systems for detection. Yeah. So a lot of work around the integrated disease surveillance and response systems, trying to improve completeness and reporting or timeliness of reporting. And we have been able, with the investments in that area, been able to reduce the time for detection since these outbreaks, the COVID pandemic, down to 50% reduction in time to detect outbreaks. So we are detecting much better. And around preparedness, we are working with the member states to make sure they have all hazard national action plans that are based on these joint external evaluations that identify where they need to improve, and that they have these plans. They are not just on the shelf, but that they are using them as tools to be able to advocate in their parliaments, in their ministries of finance, to invest more in preparedness. And right now, since the pandemic, 22 countries have developed these very detailed plans, and the idea is that you review these plans every year, update them based on the situation. So a lot happening around preparedness, detection, and response. We are not yet there. It's an uphill task, but we are in a better place than we were in 2020 when we had this pandemic.
Yeah, thank you. That's really very impressive accomplishments, and maybe this is one of the silver linings of the COVID-19 pandemic, is these amazing achievements in the African continent. Thank you, Fiona. I'm going to go back to you, Ashwin, and I know that you became commissioner towards the tail end of the worst of the COVID-19 pandemic, but then you had to deal with the Mpox outbreak, and I'm wondering how the lessons you mentioned in terms of the COVID response, how did you take those to heart as you were trying to navigate the city during the Mpox outbreak of a couple of years ago?
It was a big challenge, in part because I think everyone was still very tuned up about COVID and using the COVID lens to judge the response to the Mpox outbreak. Very different viruses, very different exposures, very different transmission, very different severity and mortality. Not unimportant, but different, just qualitatively and quantitatively different. And yet some of the same principles were brought to the fore around speed, around equity, around community engagement. And thankfully, we have such a strong community support here in New York and across the country, where they mobilized very quickly. And in many ways, they took the information we created and disseminated it and brought it through credible messengers. So all those principles I outlined around who's doing the communicating and where and when, that community, the LGBTQ community, the MSM community, they have a long and well-worn and very painful history of having to fight for their rights and organize. So to the point around where are those mutual aid networks, where are those mutual communication networks, those are already in place. And so that led to pretty fast behavior change. On the medical countermeasure front, I think it was very tough because we had a vaccine and it was not mobilized fast enough at the federal level. And so we were in a very difficult spot of having some, and we were the first city in the country and one of the first in the world to actually start doing pre-exposure prophylactic vaccination. And that was a brave thing to do. We did so thinking that would be a great proof of concept for the federal government to say, let's get you as much vaccine as you need, because we were the epicenter. Unfortunately, that didn't materialize immediately. There were delays and wait lines. And so the story became the delays instead of the fact that we were getting out ahead of it. So we needed that to be matched with action from other levels of government. Thankfully, it finally came, and you can see in the epidemic curve we bent. But those early weeks were extremely challenging, both on the equity front and just the deploying of medical countermeasures, vaccination particularly.
Yeah, maybe going to you, Mitch, and building on what Ashwin just said. I mean, it exemplified the impacts, kind of other aspects, and particularly highlight the issue of stigma and stigmatized populations, and how does stigma intersect with trust or distrust, and what are ways in which you think that we can, through PRI or through the way we think and what we do, we can combat the mistrust, and often that's intertwined with also stigma and discrimination.
Well, let's talk about the question of trust first. There's been a lot of discussion about misinformation, rumors, inaccurate information in these events. And there's some sense that there's some silver bullet. Like if you can just say the message the right way, it will get through to people somehow, that this is just about sort of perfect communication. Good, transparent communication is important. But what scholars have found, Sarah Gorman and others have found, that the reason that people are most susceptible to misinformation or to believing stigma about something, leaning into prejudice or violence, is not actually about the communication. It's about their own lack of access to quality healthcare services. That is, if you're in a situation where you're in a public health emergency and the government is telling you this or that thing, but you have never found yourself with the access you and your family needs to healthcare or public health services because of the way healthcare is structured in this country, your ability to believe that message is just very low. You're much more likely to believe some other less credible voice just because this system that is saying it's going to help you has not served you until this point. So why would you believe them in the emergency? So to me, the thing that's incumbent on all of us is not to believe that when the time comes and the emergency happens, we can speak and be believed, but how do we build the day-to-day infrastructure to support human flourishing across the board? Because that is what will really lift trust and reduce the stigma or prejudice that sort of flows out of that insecurity that people have day to day. That's what I would love to see us focus on, is build healthcare and public health access for everybody.
Thank you, Mitch. Finally, I want to sort of go around the room here, and I have one final question for you, and it needs to be very brief and maybe one word or two words. And one, at least this is the final question, is maybe starting with you, Ashwin. What do you think, from your perspective, is the greatest vulnerability that we have if another pandemic emerges, were to emerge? And you can only pick one, and then I'll get to Mitch and Fiona.
I would say if I had to pick one word, it's cooperation. And while there may be local spirit of cooperation, that local spirit needs to be resourced. And what we're seeing from leaders at other levels of government is a desire to cooperate less, to pull inward, to be more insular. And we know that pandemics don't care about that. We know that viruses don't care about that, that we are the human project is the most important project we have for our survival. And it only survives in a spirit of cooperation, and that cooperation needs leadership and resources, and that leadership and resources is being threatened at the moment globally as well as domestically. So I think that's the biggest threat, is the lack of cooperation.
Thank you, Ashwin. And maybe I'll get to you, Mitch. What do you think our greatest vulnerability is?
I read pandemic flu plans for fun. And one of the most startling plans I ever read was the 2008 North Carolina plan for pan flu, before H1N1, back when I was working on New York City's pandemic influenza plan. And on the front page, it said, "This plan will not address solidarity because solidarity is not an American value." So it was about governmental services, but it said explicitly, we're not going to go there. That's not what we're going to do. And I do think that that word, this question of solidarity across classes, solidarity of all peoples, is what will help us stand or fall both as a local and a global community in the next pandemic.
Thank you, Mitch. And then finally to you, Fiona, from your perspective, what's the one thing, the one vulnerability that worries you?
Yeah, I'm with Ashwin on this. It's an interconnected world. COVID has taught us that, and unless we have global cooperation to address these crises, I do not think we will be in a strong position to tackle future crises. So it's the global collaboration that is it for me as well.
Great. Well, thank you very much to all of our speaker, our panelists today for this really terrific discussion. And I think when one of your slides, Ashwin, you mentioned we have to fight. We have to continue to fight for the health of the people we care about, the health of communities, and we have to also try to counter this movement towards more isolationism, nationalism, and so on, which goes counter to all the tenets of collaboration and cooperation. So I want to thank you all for your contributions today. I want to thank the audience and for your very thoughtful comments, and invite you to join us at our next ICAP Grand Rounds. So thank you and have a good day.
Thank you.
Thank you.